Let's talk about this case number 5, involving a 52-year-old female with history of diabetes and hypertension who presents in the emergency department with complaint of abdominal pain, nausea, and vomiting for 2 days. Prior to that, 3 days ago, this patient had colicky pain. On presentation, her vitals were stable on room air. On physical exam, she had diffuse abdominal tenderness, distended abdomen, and decreased bowel sounds. Lab workup showed on CBC her white count is mildly elevated to 11, otherwise normal hemoglobin. On comprehensive metabolic panel, normal electrolytes, normal LFTs, and serum lipase is normal. Plain radiograph of abdomen showed pneumobilia, biliary calculi, and small bowel obstruction. So basically, stones in the biliary tree, air in the biliary tree, and obstruction of small bowel. So the questions were: the first question is, what's the most likely diagnosis? Is it acute cholecystitis? Is it acute diverticulitis? Is it colon cancer? Is it acute pancreatitis? Or gallstone ileus? Second question is, what's the pathogenesis or pathophysiology of this condition, or how does it develop? The third question is, how do you treat this condition, or what can you do for this patient? In addressing those questions in order, what's the most likely diagnosis? Do we think this patient has acute cholecystitis? What is the typical presentation of cholecystitis? Acute cholecystitis. And also, based on symptoms, physical exam, labs, imaging, and everything, do we think this patient has acute cholecystitis? She has risk factors. She has nausea and vomiting. She has diffuse abdominal tenderness on physical exam, did not have right upper quadrant pain, did not get a positive Murphy's sign. She had some stones in the biliary tree. There was no evidence of inflammation around the gallbladder itself, at least based on this imaging. With acute cholecystitis, based on the level of obstruction, you can have some abnormality with LFTs, but in this case, she didn't have any fever, no signs of inflammation around the gallbladder itself, normal LFTs. So acute cholecystitis is also less likely. And also on presentation, she didn't have right upper quadrant pain that could radiate to the right upper, to the shoulder, which can be a presentation for all patients, but overall, it did not fit the picture of acute cholecystitis. Choice B, acute diverticulitis. How does it present? This is inflammation or infection in the areas of those areas of the colon where there is outpouching, possible outpouching of the colon. Typical presentations: nausea and vomiting, bowel habit changes, and this patient, she had some nausea and vomiting, but no bowel changes, no localized tenderness, and her white count is not that elevated. So her presentation also doesn't fit the picture of acute diverticulitis. Choice C is colon cancer. Colon cancer, most common in the older patients, but can happen at any age. If there's obstruction and lesion, colonic lesion, you can have signs of obstruction. You can have GI bleeding. You can have anemia. On physical exam might show some sort of mass, which this patient did not have, and She did not report any bowel habit changes, no history of anemia, no history of GI bleed. So colon cancer is also less likely. The other choice is acute pancreatitis. Yes, she does have abdominal tenderness. Patient reported abdominal pain. She does have nausea and vomiting, but on physical exam, she had diffuse abdominal tenderness. Her abdomen is distended. Bowel sounds are decreased. Lipase is normal. She did not have significant leukocytosis with normal lipase and everything. Vitals, labs, physical exam, imaging. This also does not fit the definition of her symptoms, and her presentation does not fit the definition of acute pancreatitis. So the only choice left is gallstone ileus. So this patient comes in, she had a few days ago, she had colicky pain. She's coming with abdominal pain, nausea and vomiting, mildly elevated white count, radiograph, simple radiograph showing pneumobilia, air in the biliary tree, and also stones in the biliary tree. But more importantly, obstruction in the small bowel. So this definitely fits the picture of a small bowel obstruction in this case. So gallstone ileus is the correct answer. As far as the pathogenesis, how does this happen? So basically what happened in this case is patient had a stone that dislodged or that originated from the gallbladder and migrated to part of the small intestine and caused obstruction. So causing obstruction, right? So this is why it's referred to as gallstone ileus. And so this is the unusual, rare complication of cholelithiasis. As far as the pathogenesis, again, it's because if there is fistula between the gallbladder and parts of the small intestine, or stomach or large intestine, if that stone migrates and gets stuck in one place, it can cause ileus. So the fistula forms between the part of duodenum or the small intestine. So cholesteroduodenal fistulas are very common, up to 60%. But you can also have, fistula between large intestine and gallbladder. You can also have fistula between gallbladder and the stomach. So basically, you can have pericholecystic inflammation after cholecystitis. So you have, cholecystitis, and then pericholecystic inflammation can lead to development of adhesions between the biliary and the enteric system, and pressure necrosis by the gallstone against the biliary wall can cause erosion and fistula formation. And if there is fistula and stone migrates from the gallbladder, and depending on the size, in most cases, if the stones are greater than 2 centimeters, it could cause obstruction. And for the most part, 50 to 70% of gallstones impact the last part of the small intestine, which is ileum, which is the narrowest segment of the intestine. You can also have jejunum and stomach affected with this sort of obstruction. Colonic obstruction tends to be in areas where there is pre-existing narrowing or inflammation. If there is if patient had diverticulitis, and if there is a stricture narrowing of part of a colon, and if a stone migrates to this narrowed area of the colon, you can have obstruction as well. So the last question is, what is the treatment? What can be done for this patient? And if you think about it, this patient has signs of obstruction. Things are not moving through. In a normal process, your GI system secretes fluid, juices, and there is peristaltic movement. Um, if you think about it, your your stomach makes 1 to 2 liters, secretes 1 to 2 liters of gastric juice, and you have pancreatic juice. You have a bile coming from the gallbladder, um, and all fluids getting secreted into or entering the small intestine. If there's obstruction downstream in the small intestine, you're gonna have accumulation of fluid or juices all in one place and not passing this point of obstruction. Thus leading to distended abdomen. And if there is no peristaltic movement, things are not flowing through, you're gonna have decreased bowel sounds, which this patient had. So obviously, patient needs, this obstruction issue to be addressed. The stone should be removed. This obstruction needs to be addressed, and it should be removed. And so she would need, or this patient would need a surgery to remove that stone. But in the meantime, before we get to that, this patient needs, some decompression treatment. She needs to be NPO, nothing by mouth, because she has nausea and vomiting, and ingestion of anything into putting anything in the system is only making things worse. And in addition to that, having something to decompress the system like NG tube um, can alleviate patients' symptoms. But ultimately, the definitive treatment is removing the obstruction. Um, so patient can have a laparoscopic um, surgery, depending on if the patient is a candidate, they can have surgery just to remove the obstruction and then address the biliary issues, removing the gallbladder itself or addressing if there are other, biliary tree problems. It can be done all at once, or if the patient is not, if the patient is one with so many comorbidities, the current problem of obstruction can be addressed, and then the biliary issues can be addressed later. But ultimately, if there is a problem, one problem is leading to another. As long as patient is a candidate for surgery, um, the obstruction can be removed and other biliary tree issues can be addressed as well. Let's take a look at this fistula between the gallbladder and the enteric system. So we'll take a look at the pathophysiology or pathogenesis of gallstone ileus here on the right side, and on the left side. Here on the right side, this patient, you can see gallbladder just underneath the liver. And here on the left side, you can see gallbladder right here with some stones and part of the small intestine or large intestine, just enteric system. And here, down here for picture C, you can see gallbladder, some sort of inflammation happening here. You can see a lot of stones there. And here you can see for picture D, completion of the fistula and abnormal connection between the gallbladder and enteric system. And here you can see the most common fistulas that can form between the enteric system and the gallbladder here. The first one is called cystoduodenal fistula between the gallbladder and the duodenum. And here is another one called cystocolic fistula So it is between the gallbladder, so you can see a fistula right here, and the colon. And here's another one between gallbladder and the stomach. So cholecystogastric fistula. So connection, abnormal connection between the gallbladder and the stomach. And picture E, you can have abnormal connection between the biliary tree. Let's say this is common bile duct and the duodenum right here, and it's proximal. So right here, proximal choledochode duodenal fistula. And for F, here is abnormal connection between the common bile duct and the duodenum, choledochoduodenal fistula. And the other complication of stones in the biliary, in the gallbladder, is that if the cystic duct is obstructed with large stone, something like this, compression of the stones on the hepatic duct can lead to something called Merisi syndrome. So if there is cholecystocholedochal fistula, so abnormal, if there is abnormal connection, or if there is compression, you can have obstruction there leading to Merisi syndrome. So here is a good picture that kind of summarizes everything that we just talked about above. So here is a gallbladder with large stone in there. You can have connection, abnormal connection between the gallbladder and the hepatic duct, abnormal connection between the gallbladder and the stomach, and connection between gallbladder and duodenum. You can have, again, connection between common bile duct and duodenum, or you can have connection between gallbladder and the colon or large intestine. Here you can see a large stone in there, an abnormal fistula. Completion stone is right in the enteric system. This could be large intestine or a small intestine, and eventually, in this case, the stone is stuck at the distal ileum. This is a small intestine, ileum, and this is large intestine. So stone is stuck here, leading to gallstone ileus. So complications of stones, gallstones, you can have, biliary colic, you can have cholecystitis, inflammation, you can have mucocele, you can have you can have fistula, perforation. We already talked about Merisi syndrome, stone getting stuck in the common bile duct, infection, um, and so forth. Stone can move and obstruct duct, leading to pancreatitis, and we already talked about this case. And there's also something called Bouvret's syndrome. The GI tract is open with the outside, and air can get into the GI tract. And if there is abnormal fistula between the gallbladder and the enteric system or the GI tract, so air can get into the biliary tree from the GI through the fistula, like that. So if I clear it up, let's say there is a fistula here between the gallbladder and the GI. Air from the GI system or enteric system can get into the biliary tree, like that. So that's why when imaging is done, you see air in the biliary tree. So abnormal connection between the gallbladder and the enteric system, air gets into the biliary tree. So this whole system will be filled with air.